42-year-old white man has chronic plaque psoriasis for which he takes combined topical vitamin D analogues and regular prednisolone. He continues to have multiple intensely itchy psoriatic plaques across his body with widespread excoriations. Which is the most appropriate next step? A. Flucloxacillin, B. Clarithromycin, C. Methotrexate, D. Phototherapy, or E. Topical retinoids. I want you to pause the video here and just take about 30 seconds to think about the correct answer. And the correct answer is D. Phototherapy. And we'll go through why in the following slides. Psoriasis describes a chronic immune-mediated inflammatory skin disorder characterized by hyperproliferation of keratinocytes, leading to thick, scaly plaques on the skin. It has a relapsing remitting course affecting the skin, nails and joints, described as psoriatic arthritis. Its etiology is unknown and is thought to relate to a combination of genetic, immune and environmental factors. The symptoms of psoriasis include the development of skin plaques, which is most common, with well-defined raised erythematous plaques with silvery white scales typically affecting extensive surfaces, can also affect the scalp, lower back and gluteal cleft. They're associated with itching, burning or pain. Further subtypes include guttate psoriasis, seen on the bottom left, with small red drop-like lesions affecting a large surface area, often triggered by streptococcal infections. Pustular psoriasis describes the development of painful, sterile pustules on erythematous skin, which can be localized or generalized. And nail changes can include pitting, ridging, onycholysis, and discoloration. Erythrodermic psoriasis presents with a widespread redness, scaling, and systemic symptoms such as fever or malaise, and this is a dermatological emergency. And psoriatic arthritis is a subtype, which presents with joint pain, swelling, stiffness, often involving the small joints of the hands and feet, as well as the associated skin lesions. Relevant investigations for psoriasis include a full clinical assessment, as it is a clinical diagnosis based on the characteristic skin lesions and history. A biopsy can be performed if there is diagnostic uncertainty if this is rare, and biopsy histology will show hyperkeratosis, parakeratosis, and Monroe microabscesses. A nail exam should be performed to assess for any nail involvement, and a relevant rheumatological screen is essential to exclude any other associated rheumatological conditions, including rheumatoid factor, which will be negative in psoriatic arthritis, ESR and CRP, which should be raised. And X-rays in psoriatic arthritis can be performed, which will demonstrate the pencil in cup deformity seen on the right. Management of psoriasis includes, for first line for mild cases, topical therapy, typically short courses of corticosteroids such as betamethasone or clobetasol. Vitamin D analogues such as calcipotriol and calcitriol can be used. Coal tar and salicylic acid are very effective, and topical calcineurin inhibitors such as tacrolimus and pimecrolimus also have a role. Phototherapy is performed for moderate cases upwards, with narrow UVB phototherapy or psoralazine plus UVA in severe cases. Systemic therapy can be considered in moderate to severe cases, including methotrexate for skin and joint disease, cyclosporin, which is only used short-term due to associated nephrotoxicity, and actretin, which is an oral retinoid, has a role in pustular psoriasis. Biologics are reserved for severe or refractory cases, typically with TNF inhibitors such as etanercept, infliximab, and adalimumab, or IL-7 or IL-23 inhibitors. Complications of psoriasis include development of psoriatic arthritis, which occurs in 30% of cases. Cardiovascular disease is common, which typically relates to the chronic inflammation seen in this disease. There are psychosocial implications associated with the skin lesions, and patients are more prone to the development of metabolic syndrome and diabetes. Erythrodermic psoriasis is a life-threatening dermatological emergency which can lead to sepsis or multi-organ failure without emergent treatment. Just going back to our stem, We can see the key features in this stem which suggests a role for phototherapy in this patient includes a diagnosis of chronic plaque psoriasis and already been using a topical vitamin D analog and regular prednisolone. He continues to have multiple intensity itchy psoriatic plaques, suggesting his disease is not controlled and hence it is moderate to severe and a step up in management is required.